Thank you, Vanessa. Madeline's asking, have you encountered survivors who are really angry about having survived? And what do you recommend in those instances?
Absolutely. Absolutely. I mean, there's a sort of, I think that happened a little bit with the case of glasses, with them saying, why did you do this to me? This wasn't part of the bargain. I don't want to be here just on my own doing this. I think that anger can be a little bit frightening to me in terms of the suicidality piece of it, because I don't want that anger. I don't want to be here. There's nothing for me here. Why do I have to live my life anymore? Can feel a little bit to me like, so I'm going to end things. So my, suicide assessment skills get used a lot more often. But also, I think in that same way, to some degree, you have to witness it. You have to accept it. You have to say, I get it. I want to hear how angry you are, because listening to their anger and accepting it is ultimately what's going to sort of bring it into some kind of perspective.
The next question is from Jill. I work in a school setting. Any thoughts on working with adolescents?
That's also another whole webinar.
Maybe the top three things that you've noticed in your career.
Yeah, I mean, one difficult thing with the postvention with adolescents, if it's a member of their school, is that adolescents can be dramatic, and there can be some competition with the level of grieving, and not always the ones who are closest in relationship to the person that died are the ones that are most at risk or the most at need of some kind of postvention. Sometimes it's the people on the periphery who have their own mental health issues and are at risk that that are the ones to pay attention to. I think it's very difficult for adolescents if they have a loss in their family. I think peer groups are so important, and often they feel like I'm the only one. Why did this happen to me? I can't connect with people anymore. They're not going to want to hang out with me anymore. So that piece of it can be very difficult. And it's really, really great when you can find other teenagers who've had lost to suicide to get together and talk about it. And the other thing that I worry about a little bit with adolescents is their tendency maybe to act out their feelings rather than express them. That being said, so, drinking, driving, all of that kind of stuff when they're upset. That being said, I also have mothers and fathers who come to me and say, I want my teenager in therapy because they're not talking about this loss and it's driving me crazy. And I don't necessarily think that them not talking about it is such a bad thing. If they're having fights or losing friends, if they're not sleeping, if they have bad grades, then you need to look at it. But sometimes adolescents really don't want to open up to their parents or their peers, about what they're going through. And they may process it with somebody, in 4 or 5 years, or they may not need to.
Thank you very much, Vanessa. Sophie's asking, what advice do you have for early career helping professionals in not overreacting to presentations of suicidality? I know for many it is the scariest part of their career.
Yeah, that's such a good question. I would read Sean Shea's book. I would get as much sort of, suicide assessment training as you can. And, I would say that this word suicide prevention is more of a public health messaging word. And as clinicians, we cannot prevent a suicide. We can assess and we can intervene and we can try and figure out the right level of care. And we can write good notes and we can involve the family and we can do things that sort of help us feel less scared. We're always going to be scared, but the more knowledge we get for ourselves, the less scared we'll be.
Do you have any tips around self-care for clinicians working with postvention, especially also things that work for you, but also other good ideas that you find that work for a lot of people And also, how to really prioritize it, not just have a list of self-care strategies that are just sitting on a piece of paper.
Yeah, yeah, yeah. No, in some ways I don't like the term self-care, and it's like massages and bubble baths and things like that. And I don't think those things ever really help as much as we want them to. I see it more as squad care. I think I have a lot of colleagues that I can call, that I can either talk about what I just went through with my postvention that brought up a lot of feelings for me, or I can talk about how nutty we are to be in this profession, or I can talk about, my kids and something totally separate. And oftentimes I think that helps the most, is sort of that group squad social support. For me, I'm into the nonverbal. I think creativity and poems and things like that are incredibly helpful. I think as a profession, clinicians talk too much, we think too much. So when I can knit or draw or paint, I think that's incredible, or be in nature and watch a sunset, I think that's incredibly helpful. And also I think sometimes, and this has taken time for me to do, I pace myself. And I get a lot of calls and I get a lot of referrals, and I don't always take them. And I sometimes say, I'm full and let me find a colleague. And I'm okay with that. I can't schedule 3 things in 1 week. I can't even sometimes, schedule three things in 1 month if I'm just feeling like in a place where I'm either busy or burnt out or tired. So I think having good boundaries is also good self-care.